Good afternoon, everyone. I'll make that 1 o'clock, so you're all very welcome to this afternoon session. We're looking at the Ardens SystmOne LTC Annual Recall System. As you can see from the slide there, my name is Dave. It's nice to be with you all, one of the training specialists here at Ardens. And Nathan, our training lead, is going to take you through the majority of the functionality. So only got an hour today. So 1 or 2 slides just to take you through initially, then we'll pass over to Nathan just to give you that understanding of the functionality of the reporting and the up-to-date templates as well. So first things first, I'm sure most of you probably joined some of our national webinars previously. First thing of note is as you join, cameras and microphones are disabled. That is intentional. We are recording the session, so we do like to have a nice clean recording for everyone to watch back. And I'm going to touch on the recording and how to access in a second or two. Just because your microphones are switched off doesn't mean that you can't ask any questions. So within the Teams meeting itself, you will see a Q&A icon along the ribbon across the top of the screen. So if you do have any questions, pop them in there. As we go through, I'll be posting various support articles that Nathan's going to touch on as well. Duration-wise, we're a bit tight for time today, so we've got an hour or so. Hopefully, we'll get through everything in that time. Mentioned earlier, session is being recorded. Everyone who's registered for today's event, whether or not they've been able to make it or attend, will be sent a copy of the recording itself. From a technical perspective, if any of you are struggling with audio as you've joined, not a great deal we can do at our end technically with regard to traffic and so on. Best advice we can give, if you're having any issues, log yourself out, rejoin the meeting. Hopefully that normally fixes that particular issue as well. Just touching on the agenda for today. So obviously, Nathan's going to take us through how to use the LTC system, how to use the reports in conjunction with the templates, maybe time for discussions on how you're going to implement the system. Next step, ongoing training. When Nathan passes back to me a little bit later on, I guess one of the caveats for today is don't feel under pressure as to this is your training and that is it. Ardens as a company are here to support you with every step within your primary care. So we will touch on later on how you can tap into one-to-one training for your practices. It is all free, so I'll give you all of the information that you need a little bit later on. Just touching on how you can implement the new recall system. When I say new, it's been in place. I'm sure some of you familiar with it anyway, but one decision you may need to make, not right here right now, but at some stage when you discuss this amongst yourselves, amongst your practice, is what system do we use? So we give you the flexibility to either use the QOF and IIF indicator reports, which will obviously highlight and identify those patients on those particular QOF or network DES registers, or you can implement the QOF and best practice conditions. Only thing to think about there is traditionally or historically you might have only dealt with QOF. If you do decide, let's go for that best practice approach, because as a practice, we want to make sure we are also monitoring patients who maybe aren't on a QOF register or a QOF register that has particular indicators, but because of those conditions, you want to make sure those patients are being seen regularly for their med reviews or their blood tests or whatever care that you provide. So I'm sure Nathan's going to touch on this as we go through, but if we did do QOF and IIF, or if we then decided QOF and best practice, I guess the things just to bear in mind is QOF, when it comes to your asthma patients, obviously it's based on the register of the correct age range, the asthma diagnosis, the medication within the last 12 months, where if you decided for that gold standard approach, I guess, QOF and best practice, those asthma patients could be those that have got a code of asthma, but who've never had or have not had the medication recently or within the last 12 months. Again, from a best practice point of view, good opportunity to review those patients. Maybe interrogate their records to find, last time they had their inhalers, maybe we do need a conversation, maybe we do need an appointment. But, at the end of the day, what we should be doing from a best practice perspective is coding those patients as their asthma resolves. So you've got the flexibility to do it whichever way you want, which we will touch on. And again, something fairly new for some of you is the coding process that goes along with those invitations, assessments, and reviews as well. Nathan's going to touch on that in a lot more detail as we get onto the reporting side of things. And then finally, just something to consider as Nathan goes through everything is what that actual process looks like to you as a practice. One of the things we do say about this system is the fact that it might take that little bit more input from other members of the team, other members within your practice, in and around how this is all going to be managed and monitored and assessed and so on. So basic principle here is we do have reports that allow you to plan your sort of financial year. Again, we'll touch on those reports as we go through, but giving you the information broken down, for example, by the amount of patients each month of the financial year that we potentially need to invite in. Again, from a management point of view, allowing you to plan maybe when we look at how many patients are due in August, and we also happen to have a healthcare and practice nurses off on annual leave. How do we manage that? Do we bring those patients in a little bit earlier than expected? So again, it gives you that plan of your financial year, your workload, what that means in terms of capacity and appointments and so on. You then move on to the notify section of the process. So this is where you would traditionally be doing your invitations for those patients for their first invite based on their month of birth. And again, more information from Nathan as we go through. Maybe the biggest change for some of you will be that assess stage at this point within the process. So the way we've designed this is you notify your patients, or in other words, invite those patients in for their annual review. That's dealt with at an initial appointment, an assessment appointment with your healthcare assistant, but potentially your nurse. They capture all of that information that's relevant, either whether it's run-of-the-mill, height, weight, blood pressure, diet, exercise, smoking, alcohol, but it also, along with that, all of the maybe the QOF and the best practice requirements. That then moves you on. Once those patients have been assessed, we've got a report folder that those patients can then be reviewed. And a decision by that nurse, by that GP, would be based on their initial appointment, their initial assessment, based on the results that are being returned by the lab. Do we consider that that patient's review has been carried out for this financial year, in which case we can complete, or alternatively, we look at that patient, maybe we've got some concerns over certain information that's been recorded by the healthcare, maybe we've got some concerns about raised bloods and so on. So at that point, we'd actually do a full-blown review face-to-face with that patient. And then final step of all of that is being able to evaluate your performance throughout the financial year as well. So again, with that, you have a breakdown of reports based on last month's activity or the financial year itself. So that's the plan for today. Try to get that through that as quickly as I possibly could. I'm going to hand over to Nathan now. So I'm going to just stop sharing my screen.
Thanks, Dave.
And then we'll come back at the end just to talk about further training and so on.
Amazing. Thanks, Dave. Now, that's teed me up nicely. So with that whole kind of process, so I'll dive into SystmOne and kind of show you how that works now. Kind of as Dave said, this is an overview, so please don't think this is your training. I just like to reiterate that because this is a lot to go through. And there might be bits that I won't touch on, like nuances. What I find is we've done lots of these sessions now with individual practices, and every practice works slightly different. So please, don't think this is it. Training is free at Ardens, and Dave will talk about that at the end. So the idea of this is give you an overview, go away, and then maybe book the training for your practice, but at least then you'll have a good idea already of how it works and you can make the most out of your session. So please don't think this is it. there's more training available, but this hopefully give you a nice overview. So just wanted to caveat that. Obviously, do ask in the Q&A if there's anything we might be able to answer now, but so just something to think about. So anyway, I'm in SystmOne. So the first bit we're going to look at is that start of that journey, that the planning, the notifying bit. So we're going to go through that process that Dave kind of had up. So we want to start in the reports, and this would be for your admin management to be running basically. So we'll start with that. Then we'll go on to like the clinician bit at the end, which is actually doing the consultations. So I'm in a patient record at the moment, but I actually want to go to our reporting screen. So going to go up to reporting. You probably all know this because you use SystmOne all the time, but we're going to go to reporting and we're going to go to clinical reporting, go to our usual screen. And as you know in here, you've got your usual layout, my reports, local reports. You've then got your Ardens Limited folder, which I'm sure you're all currently using in one way or another. We just want to open that up because those are all of the reports that we build for you. And then it basically is A to Z in there. And if I go down, so I've already got it open, but basically what you'll see in there is LTC review, and there's just a few in here. So we've got LTC review, QOF, IIF best practice. So like Dave was saying, it's that kind of, that's everything. It's the all encompassing every condition you'd ever review. So if you want to go down that route, you'd use that folder. Or you've just got QOF, IIF, which is just the QOF conditions plus learning disability conditions. So that's like I love to say bare minimum, but that's just your QOF registers. So that's going to be less patients than the QOF and best practice. There's no right or wrong. It's however you want to approach it as a practice. You could move from one to the other. That is fine. It's all using the same codes. Essentially, the process is exactly the same. The only difference is that folder is going to contain more patients than that one. Other than that, so I'm going to go through the QOF and best practice folder. If you decide as a practice to do QOF, don't worry, everything I'll show you will be exactly the same. It will just be less patients. So it doesn't matter that I'm only going through one of those folders. You will notice in here as well, there is interim for both best practice and just QOF. I'll touch on that on the end. That's more if you wanted to use our reports to follow up and do like a 6-monthly review for like heart failure patients or something. There is the ability to do that, but I don't want to run before I can walk. So we'll focus that once I've done everything else. But for now, I'm going to open up the LTC review, QOF, IIF, best practice, and annual, because this is designed for that annual review. So if we open that up, then we've got all of our subfolders. Now, annoyingly, SystmOne only allows you so many subfolders. So we've had to kind of put each section, there might be 4 separate folders, but if you imagine, like Dave showed you, got like 1 plan, 2 notify. We've mirrored that here. So you've got all of the plan reports, notify, assess, review, evaluate, and it's done 1, 2, 3, 4, 5. So we're going to look at the plan. I mean, to be honest, actually, what I like to say is most of the time you're all going to be sat in the notify section, those that are doing this bit, and you're going to be running those notify reports where it says invites first. That's where you'd be doing your invites. So I will touch on that in a minute, but the majority of the time that would be your general workflow. You'd be working from those. But we like to touch on the plans just so you understand what's going on, because you might want to plan ahead, like Dave said. You might want to look at capacity. How many patients are we actually going to be calling in? It's just all about looking at the data and making sure that you're prepared to do this. It doesn't matter when you run these ones, they're just there to help. You might not run them much, but they're useful to have. So the first one we've got is plan conditions. Literally top one there, QOF, IIF best practice, all. That is essentially going to show you your cohort of patients that have one of those conditions that was on the spot. By the way, as well, when we share the recording, we will share the slides, so you will be able to see that, and they're all on the support article and they're listed there as well. So if you wonder why I keep meaning, they're listed there and they will be on any information we send out to you. But essentially, that number there would be the total number of patients in that year that I would be calling in. Whether they all come in or not, it's another matter. But in theory, that's who can come in. But then we break it down by condition. Now, you'll notice that this a lot. It says CVRM, so that's your cardiovascular, renal, metabolic diseases, all lumped together. So like, cardiovascular, diabetes, etc. So that would tell me in total that's 4,906. But then it breaks it down even further by everyone with atrial fibrillation, CHD. It's essentially your registers. And you can just check how many are on each register. You can check if a patient's on a register. Obviously, you can do that in other places, but if you ever need to see what we're inviting for, all of the patients will be sat on those reports. And that is basically it, just a nice overview, so you can get a gist of numbers. So that's all that one does. The next subfolder, exceptions. Now, on the PowerPoint, Dave showed you the codes briefly, and we didn't want to get into nuances of those because we don't want to confuse you. But in this process, there is the ability to remove a patient or a group of patients or whoever you want from the Ardens invite reports, because it might be that they are seen elsewhere, secondary care, maybe a community team sees them for that condition, you don't need to call them in, maybe you manage it in another way. So you could go to the conditions as an example, and I could choose like my MGUS patients, check if they've got anything else, and I could add a code to them to stop them from being invited, so you're not necessarily inviting them in. Obviously, we wouldn't know exactly what condition you want to do that for, that's up to you, but if we go to the exceptions, this report will tell us how many patients have had the code added to them, which removes them from the invite reports. It is chronic disease default from follow-up. It is all on the support articles, but if I literally just right click and go show information on that report, it will tell you it's this code. Look, has a code of chronic disease default from follow-up 17055. So that's the code. If you add that code to the patient's notes, there's an easy way to do it on the template as well, which I'll show you in a minute. Basically that code, they don't get an invite, but you have to re-add it every year. So if I added that code to a patient today, they wouldn't get invited this year, but come the 1st of April, they will fall back onto the invites. So I'd have to re-add it because you'd want to review to see if they should be coming in. That report shows you who's had that code added. Simple as that. So you can just use that as and when. Recall month. So as you know, this system, again, kind of taking a step back, it will essentially go, right, has any of those conditions that we were talking about, and it divides it by 12, which is their month of birth. And this report shows you who falls into each month of birth. Don't use these for your invites. This is purely just to get an idea of numbers. So as we can see, this poor practice, if I go down to March, they've actually got the most number of patients to call in March, which is probably the worst month because you've only got a month to get everything done. But at least you would be able to plan ahead and go, actually, we need more staff available in March, etc. So you can use those reports for that. What you will notice as well, especially on this March one, the total number of patients that could potentially be called in March is 589. 588 of them, it's because that's their birth month. One of those patients has chosen March as the month that they want to come in. And there is an ability to add a code to a patient record, and it would move those patients or that patient to another month. So for example, you might have students, they're never there in the summer, so you can move them to a month in term time. Or you've got a husband who wants to come in when their wife comes in because they have special, they need to be escorted in or something. So you could move that person to July rather than having their May birthday. So number of reasons why you might do that. Again, I will show you how you do that on the patient record when I get to it, and you can do it in bulk. And there is stuff on the support article telling you how to do that. And we can cover that if you book any individual training. It's more just knowing that you can do that, and that could be useful, especially if, you might actually just want to bung all those patients in March to another month, or split them between 10 months or something. So loads of ways you could do that, and that shows you how many fall into each month. Review before is just some useful reports you can run before you send your invites out. Now you can run these whenever you like. One that I want to touch on is what Dave was talking about, those asthma patients. Now we've got one here. If I just highlight that report there, it basically says, consider if a review is required. If not, then record as default to follow up. So that's that default to follow up code, which removes them from the invites, or code asthma resolved. And it's basically, it says next thing, it says these patients are asthma patients who have not had any asthma related drug prescribed to them in the last 12 months, and they don't have any other condition. So like Dave said, you might have patients that were coded 5-10 years ago as having asthma. Maybe they had their inhaler a couple of times because they were 15 or something, or it's because of hay or whatever, but then it's probably gone away, but they've never come to the doctor because they're pretty fit and healthy. So then you guys wouldn't know haven't got asthma anymore unless you've reviewed their notes. Therefore, they might be sat there saying they've got a diagnosis of asthma when they probably don't. It's probably been resolved. They would suddenly get an invite using the cough and best practice, but they would be sat on that list of patients. So what you could do is maybe review those patients before you do your invites and just be like, actually, do you know what? Let's just add the default to follow-up code and we'll deal with those separately. Or maybe it's like, no, let's get them in. So however you deal with that, it's up to you. But at least we're going, look, these patients you might want to check before you do the invites because they might have had their inhaler for a while. So again, just a useful one. And there's just a few others like the one below it, epileptic patients who have not had drug therapy in the last 6 months, and also they don't have any other condition. So I can look at those 20 and I go, oh, actually, their epilepsy is fine. Do I need to call them in? Should we review it? And you can clear up your lists. So just useful stuff. One other one I'll just quickly highlight, that top one there is basically telling you, do you want to change the month they get called in? Because they had a review in Q4, but they've got a birth month in Q1. So my birthday's in May, but if I was lazy last year and only came in March and had my review done in March, if you use our system, I'm going to get an invite the next month to come in May. And I'll be like, well, I only came in last month. Why am I being invited in? But I would be sat on that report. And then you could decide, well, actually, I'm going to move Nathan's recall to next March so it's in sync for a year. So again, don't have to, but it allows you to do that sort of thing. So it's all planning ahead, reviewing before, making sure that, it's as slick as it can be. Our support article does go into more detail of this as well. So it is all on there. But again, just something to think about. And then the setup, I probably don't need to cover this too much, but the plan setup, essentially that report there, those are the codes that we use in our system. That's going to tell you if you've used any of those codes in the last 12 months. If you've never used the Ardens LTC process before, and those codes have been added for something else, it might affect if they appear on the invites or not. So that report will just allow you to review those patients, work out which code was added and why, and just make sure they get an invite. If you've used our system before, there is absolutely no point in running that because they're just going to appear anyway. But it's just something to think about if you are just starting this for the first time. But that's the plan section. I don't want to labor too much, but hopefully that makes sense. Now, we now get onto the nitty-gritty of actually, now we've had a look at all that, let's do our invites. So like I said, you've got notify invites first. That's where you send your invites out from. And as you can see, I'm going to cover the asthma-only one above it in a minute, but there's a reason I do it this order. So literally divided by month of birth, like we said. So can you see it's just done it like this? For first invite in March, for April recall month. So just something to look out for. All of those reports I've just highlighted, they are actually looking at invites in March, but for April birthday. So they are all people that would be recalled in April. It's just giving you the month before. You can use that report. You could use that now. You don't have to do that in March. It's just the way it's worded. But always think that's for the month ahead. So then you've got April, but all of those would be for May birthdays. Those are June birthdays, July. So if we're doing this properly, that report there is everyone at my practice with one of those long-term conditions with a recall month of July, and that's who I need to invite in because those patients will be sat there, currently haven't had an invite and they haven't had their reviews done using the Ardens LTC process. So that in theory is your list of patients to invite. Now, before I just go through the difference between those actual reports, I've got when I last run that, there was 457 patients on there. That includes currently patients that have asthma, but no other condition. Those ones I was talking about earlier. Now, it might be that you think, do you know what? Well, actually, they could have had an inhaler in the last year. That's not just over in a year. It's basically anyone with asthma, whether they've had an inhaler or not in the last year, but they don't have any other condition. So they'll be sat on there, but you might think, well, they don't have anything else. Do I need to call them in? So what I could do is I could go to the asthma onlys, which is a separate subfolder above first invites. And that report at the top is all of them, but it basically breaks it down by month. So where are we? So July recall, because we're looking at next month. I have 42 patients sat on there that have asthma, don't have any other condition. They're currently sat on the other one. It's like, well, why would I invite them in? Why don't I just send them a questionnaire? So you could send those patients a questionnaire. Now, you might use AccuRx. Great. I don't have AccuRx, so I can't show you that bit, but you could use that, get that list of patients, send them all a questionnaire. Or you could use the communications analyst in SystmOne. Now, I'm not going to go through the whole process here, but if you were to right click and go actions, the third from bottom option is use communications annex. And you could use the communications annex to basically bulk send them all one of our questionnaires. And one of the questionnaires in there is called, it's an Ardens one, and it's an asthma questionnaire. Now, I don't want to go, because we've only got an hour and I don't want to go into the whole thing. There is a support article on this and it's all part of that, and we will send, Dave will share, but I'll also send links out when we send the video, so you will have access to where you can go through and send this questionnaire. And if you book individual training, I'll do it then, but I don't want to waste time going through it now just because of time constraints. But you could use Communications Annex and basically send them the questionnaire and code the invite code, which I'll talk about in a minute. And if they fill it out using the SystmOne Communications Annex questionnaire that we've built, it will come back into SystmOne and it will essentially, someone will review it and it will code it. And essentially it will do the review without having to see the patient. Someone just needs to review it, check the ACT scores all right, and then decide what they want to do next. But in that essence, you've then freed up, I mean, best case scenario, 42 patients that don't now need to come in. So just worth knowing. If you don't do that, they'll get invited in on the first invites. That's fine, but you might want to do that there. And it does say add invite code, because if you add the invite code, which I'll tell you in a minute what it is, if I added that code to all 42 I sent the questionnaire to, when I rerun that report tomorrow, that would be 0. And what would then happen is, if I go to invites first, so it's really important you leave it a day if you do that. So if you imagine you started this next Monday, do your questionnaires and code the invite code. Tuesday, rerun this report, and there should be 412 patients on there because we got rid of the 45 or however many it was. So it will get rid of those, it will knock them off, so you don't have to send them another invite. If you do the questionnaires, asthma questionnaires and the first invites here the same day, they're just going to be on both, so you have to leave it a day. But it's just worth thinking, get rid of them, and then everyone else sat on there is essentially has any other those. They might have asthma patients on there who have diabetes. They wouldn't be cleared because they'd need to be invited in to have a review and bloods and things. So, and then you've got everyone else that you need to invite. Now, what we're doing here is essentially we are inviting in for that initial assessment. So it's for them to come in, and no matter what they've got, get them in, and then the template will facilitate a way where you can go like, right, okay, let me take your blood pressure, pulse, oh, let me ask you these lifestyle questions, oh, you know, let me check this. And in a way you can collate all the information needed, so when the bloods come back in, someone can go, yeah, all looks fine, in a best case scenario. So think of it like that. So at this point we're going to come in for the bloods. I appreciate everyone works differently. You might have a different nuance. That's fine. We can discuss that when we do individual training with you. So, you know, it is flexible, but that's how this has been designed. So that's how I'm talking about it. So you've got all. So let's just say I've got rid of the asthmas and now I've got 457. Now I would not run that one. All of the reports below it add up to that top one. So they are all mutually exclusive of one another. So rather than do that, there might be patients that need certain nuances, or might not want to bulk send them an invite. So what you would actually do is start on these, and these two, consider method. Basically, you need to check them before you send the invite, because that one is anyone with one of those conditions, but they're under 16. And really, you'd look at those 10 patients and go, well, who am I actually sending the invite to? Is it the mum, the dad, the carer? Whose mobile phone is it? How do I word it? Whatever. But you need to invite them or call them, because you wouldn't send them a text because you're like, well, you're not inviting a 14-year-old. They probably don't have well, they probably do have a mobile, but you might not have their mobile phone number. So it just allows you to see who you're inviting and inviting them as appropriate. Or do you need to invite them in? And again, some practices don't deal with 15 or younger, so it's up to you, but that would show you those. And as long as when you invite them, and I'll keep banging on about this, every report it says then record LTC invite, and it's 88782. It's that code there. That is the code we use on our system to invite patients in. It is not a QOF invite code, and I'll touch that in a bit, but it is the code we use. You could add the individual QOF invite codes if you want. You don't have to. We have a ways and means of mopping that up at the end of the year. But if you add those, it's fine, but you have to add this code because our reports are built around that code. So that is the code you add for your asthmas, but also for your first, second and third invites, because it removes them from these invite reports. So if I invited all of those 10 patients, if I add that code tomorrow, that would be 0 because they've had that code added. Simple as that. Right, the next consider method is any patient has one of those conditions, born in July, but they also have end of life or dementia or a learning disability or a reasonable adjustment. And again, it just highlights those patients, ring fences and go, these 17 patients you probably want to have a look at, because if they're on end of life, do you want to call them in, or do you want to add the code to remove them from the invites? Or dementia, who, let's send it to their carer. Are they going to understand why they're coming in? They've got a learning disability. Do we need to communicate to them in a certain way? Reasonable adjustment, same sort of thing. Can they read? Whatever, do they speak the language? Whatever it is at your practice. But again, you can review those 17 and invite them how they need to be invited, and then add the invite code. And then that will be 0 tomorrow once you've added that code. So essentially, those guys need something doing to them before you send the invite or checking. Then this one will be the bulk of your patients. This is where you mainly do your invites, because that 394 all have a preferred contact method of either SMS, email, AirMid, or set as unknown. They're not in these. So for want of a better word, they're your normal patients. They don't have anything that you need to worry about before you invite them. I mean, there might be, but there's no communication style that you need to send. You can just text them or email them or however you want to do it. And the idea is you might want to know what conditions they've got. And there is an output. Now, again, I can't show you this, but it is on the support article. So on the support article, we tell you how you can basically, when you run that, you can get the list of patients up, and then at the top, you can select an output and it will show you what conditions they have it just changes the screen. And again, this is something we can do with you on your individual training. So just know that you can do this, and it will give you, so for example, you could then click on the diabetes header and you'd have a list of all your diabetics, and you could highlight those diabetics and you could send them a slightly different invite to everyone else, or you might just want to send them all a booking link or so again, it's up to you how you actually invite them, because you could send them a booking link, you can use AccureX, all of those. We're just saying these 394 need an invite, and because they can have a text, you can just text them or email them. If you do use, again, don't forget, if you go to actions, you could use the communications annex and you would be able to bulk send them a text, or there is the option to go, where is it? Send patient appointment invitation. Now, we can't set those up for you, but that would send them a booking link. And I think you could do something similar in AccureX, I'm not sure. That you go to put this appointment for a 30-minute LTC review initial assessment. So again, lots of nuances, but you can do that from there. And we can have that chat with your individual practice if you book training. So invite them in, and then add the invite code, and again, that would be 0 tomorrow. Next one, there's a bit of a weird thing here. So this one is their preferred contact method in SystmOne is set as letter. That does not mean they don't have a mobile phone. So again, just something to think about. Now, I would run that, and what I would actually do is once it's run, I would right click and break down the results like so. And what it will allow you to do is on the left hand side, I've already done it, but if you open up if you've broken down reports before, you'll know exactly what I mean here. If you open up demographics, you would be able to tick users mobile, refresh the screen, and can you see there 48 out of those 65 patients actually have a mobile phone, so I can still text them. Again, that has to be practice policy. That's not for me to say they might do double check, but you could say your practice policy is to be like, well, we're going to text you because you've got a mobile phone. I know you would rather have a letter, but it costs us money and it's easier via text. That 17 though don't have a mobile, so you'd have to decide how to invite them, whether you call them, send them a letter, see if they've got an email address. So again, it's up to you, but we're just making it easy for you to distinguish what those are and invite them. I'll just close that. But as long as those 65 are invited, add the invite code and it will remove them. So in theory, if you went through all of those, once you've done them all, the next day they've all been done, that should say 0 because they've all had the invite code added to them and they've been invited for that initial assessment. You'll notice there's a no communication. It's very unlikely you'll have anyone on that, but if you've had a patient that says their preferred contact method is don't contact me, then they would be on there, and then you just have to decide what the hell to do with them. Do you invite them? Do you not? Do you just exempt them? Again, it's very unlikely you'd have it on there, but that's what that's doing. But it might look a lot, but really those two can just have a text or get called. Those two you just need to check before you do that, and once those are cleared, you've invited everyone for that month. Now, I'll go on to the template in a minute, but essentially once you've added that invite code, after 2 weeks, if they do not come in and have their initial assessment, they will drop on the left hand side to invites second. and it's exactly the same process. You don't need to go through exactly the same reports, but essentially that report at the top is any patient that had that invite code added 2 or more weeks ago, up to 3 months. So 2 weeks to 3 months ago, and have not had the initial assessment coded, and I'll show you where that's done in a minute. And the idea is you run that and you invite them again. We invited you last month. Now it's 2 weeks. Doesn't mean you have to do it after 2 weeks. You could leave it a month to run these. It's completely up to you. But those are everyone that needs a second invite. And again, you just do the same again, and then you add the same invite code. And once you add that code to those patients, it will move them on to the third invite after another 2 weeks. So it's very simple. First invite code, second invite code, third invite code. If they come in at any point and have the initial assessment done, they drop off these reports. These are only patients that have not had the initial assessment coded. So it's quite robust, easy. Invite code, invite code, invite code. There is this one underneath, notify invites to chase. This, to be honest, that bottom one's the most useful. Well, they're all useful, but that bottom one says for chasing as third invite was more than 1 month ago and they've still not come in. That's your safety net. I've sent 3 invites, they've still not come in. What am I going to do with these patients? So you can use that for your safety net. The 2 above it are basically saying they had a first invite, but the second invite wasn't added, or they had a second invite, but the third invite has not been added. So again, if basically just look at these patients and work out what's going on, but it's to mop those up. And then lastly, you've got your visits. So anyone, you might have noticed sometimes people looking at go, well, what about my care homes? How do I take those out? We've already taken them out for you. They are not on those invites. They are separate. So as you can see there, look, care home residents or housebound. And if you run those are your lit. If you have those, if you don't, that's fine. But you'll be able to go, here's all my care home patients. I'll give that to the district nurses, or they're dealing with them already. You're not inviting them. You just need to know who they are to make sure they get some sort of review. So again, that just allows you to review that information if you need to. Simple as that. There's not much more to that one. So I'm hoping that makes sense. Before I jump into the template, Dave, is there anything in the Q&A I should highlight or?
Not really, Nathan. Everything's been answered. There's just been one popped on by Louise around, can you add the invite code in bulk?
Yes, you can. Sorry, Louise. Yeah. Good question. Thank you. I always kind of assumed, but then I didn't. So if you do it on the communications annex, you can add a code in bulk there. So let's just say I was going to text all 50 patients with a condition, or I use the communications annex. I can't show you, but you can basically add the code in there and it will bulk add it at the same time as sending the text. So you can do it there. If you don't do it that way, for example, on June for July, literally, if I wanted to add a code to those 457, I can literally right click actions and the top option is add read code. You can just search for it, click OK. You can put a note on with it, click OK, and it adds it to all of those records. It's about 3 clicks. But it depends. If you do if you're sending text out on the communications annex, I would do it on there, because you don't have to then do it again. It's all done in one place. But either or. And again, if you're not sure, the support article will show you, and we can show you on training. But yeah, I hope that answers it. But yeah, pretty simple. Cool. Then I might jump in because I'm conscious of time, because there's a lot to go through, and I'm gonna have to be a bit broad of some of this, but I'm hoping it gives everyone an idea. So that invite's gone out. Hopefully the patient will call up and book an appointment with the HCA, and then they come on in. Now, the idea behind this is you do everything in one go. I know that won't always work, and I know this all depends on skill sets and everything. So please, I know it, but if I show you how it's designed, you can see how it might work for your practice. And again, have a chat with us when you book training. But I'm the HCA, patient's in with me, bring up their notes. And what I'm going to do is I'm going to go to the LTC template. Now, if you don't already know, I famously always say it's the goalkeeper, and now it's the World Cup. Seems a bit apt. So that green man, still in front of the football net, click on that, and that's going to open up the Ardens LTC template. So I'm going to click on it, and every patient will have it up there, and it will open it up like so. And here we have the template. You've got tabs across the top, or the links to those pages down the side. Now, to be honest, most of the time in this template, if I was the HCA, I don't care about anything other than the initial assessment tab there. And if I'm the GP following up, all I really care about is the review tab. So the majority of the time, the clinicians will be using those 2 tabs. So just bear that in mind. I'm going to go through the others quickly, but they wouldn't need to go through those. They'd only really need those 2 tabs. This front page, though, you can go to the pages. you remember I said at the start, you can change the month they come in. So there, this button here, let's choose LTC review month. If I click that, it will open up this and I can go, actually, I want to come in May or January or whatever. So you tick the month and then you just have to tick that again. And that would move that patient to that month going forward. Simple as that. You can do that in bulk. It is on the support article, which codes are what. I won't go for that now, but just bear in mind you can do that in bulk. But other than that, that's that. And also look, default from follow-up. So that's that code I talked about, which removes them from our invites. So if you click that button, it will tell you what it's doing. Like this, to stop a patient being invited, it tells you, you can't go wrong. And if you click the button, it adds the code. Again, you can do that in bulk, but if you want to do it ad hoc, you can do it from the template. Nice and easy. So that's those two buttons, just worth knowing down there. But I'm going to go through the tabs. So I'm going to go to the invitations tab first. I would say the only person that really needs this is your admin team who are doing the invites. And they could look at this and they'll be able to see how many reviews have they had. Like, have they had a review in the last 15 months? How many invites have we sent in the last 15 months? So I can see at a glance if I've done the invites and if they've got any pending appointments. I would say that's useful because if you, we have a lot of questions to the support desk and it's like, oh, I thought I added the code to this patient, but they've not come off this report and blah, 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 blah. The first place I would go is this screen because you can see, did I add the right invite code? It will tell you there, you know, when did I add it? And, you know, and then it will give you an idea of what report they would be on. So if it was added for, you know, over 2 weeks ago and there's only one code on there, I would know that they would be starting the second invites as long as they haven't got an initial assessment code done or something like that. So just useful for that, really. Just check, did I add the code? Go here, it will tell you. So just good for admin, really. You can do an ad hoc invite. So where it says LTC invite there, if I was to click on that, I could go, oh, I verbally sent them a first invite, and it would then actually tell you if you want to code the invite codes as well, including the QoF invite code at this point. They say we don't bother to tell you, but you can if you want. So it would do that. Most of that would be done in bulk. I don't think you need to use that, but you could if you wanted to. So that's that. But other than that, that's that page. And again, the booking page just gives you an overview of, okay, that's the conditions that they've got, any pending appointments, and then they can click on the right-hand side here and go to the free slots or check the appointment screen and book the appointment. A lot of practices might have their own, they might send a booking link. If you do that, you don't need to use that page, but you could if you want. And it can even suggest appointment links at the bottom, which you can tweak, and it tells you how to do it on that page. I won't go into that information now. You don't have to use that, but you could set something up. And again, that's something we could look at with you in your training, because again, everyone's going to be different. And I don't want to open that kind of worms, but for now, think of this page as this is what you've got, book the appointment. But it might be you've already got it booked, but you could use it for that. And then the questionnaires tab will show you any questionnaires this patient's filled out and been filed to the record. So it could have been that asthma questionnaire or diabetes or whatever. And you could also click send message to bring up the communications annex to send them a new one. Again, not imperative. It's one of these things. Knowledge is power. If you know that's what that page does, you know if it's useful. But that's what those first few tabs are doing. But now we're going to get on to the actual review. So like I said, I'm the HCA, patient's in with me. I'm just going to go straight to the initial assessment and test tab. And what this is doing is it is telling me everything I need in one place. So it is saying, if I start from the top and work my way down, it tells me that this patient's got CKD, diabetes, heart failure, and they are all QoF conditions. So it tells you if it's a QoF condition or not, which is useful. They've got asthma, and they have been given meds in the last year, and they don't have anything else. So I know exactly what they've got wrong with them. It will then tell me exactly what bloods are required based off of the conditions that they've got. Now, it says not done in the last 2 months. That's basically saying that, but it's not saying you need to do that every 2 months. This template is designed to be done during the annual review, at no other time, just the annual review. They might have come in for something else and had their FVCs done 3 months ago. But because it's now the annual review, because it's been more than 2 months since that was coded, that might have changed in 3 months. So that's why it's saying not done in the last 2 months. Whereas if they came in last week for something completely different and randomly had one of those HbA1c done then, when I look at this, it was done last week, so I don't need to do it again, because that's kind of probably wouldn't have changed. So what's the point? Let's not waste time. So that's why it's telling you that. And it will have a green tick to say it's been done in the last 2 months on there. And then it also says blood test overdue. And again, it's telling you about the FVC using these LFTs because they're on a DOAC. So the ones with the test tubes are based off of the condition that they've got. This bit of wording will list if they've got any medication that needs monitoring as well. So again, quite useful. And then it says like, they also blood pressure, pulse, urine needs doing. And then it also shows you what outstanding work there is. So these, BMI hasn't been done, smoking, lifestyle advice, depression screening, blood pressure, all of that is on there as well to, so I could look at that and go, that's what I need to code. And it's basically since the 1st of April. So it's all best practice and not just QOF, it's kind of everything. So basically it's going, do these bloods, and these are other things you might want to ask. Now, this next step totally depends on the skill sets of your HCAs, what they can do, how long you've got, I appreciate. So please don't worry about that for now. If you understand what you could do at this point, this will make sense. So it might be that you just ask the lifestyle questions and you've got a link to the lifestyle template, height, weight, do you smoke, how are you feeling? That might be enough. That might be all they do, and the bloods. Or they might just do the bloods. So if I click LTC tests, it takes me to the page to go to ICE, raise the blood form, code, I've done the bloods. That might be enough. Again, depends. But in an ideal world, what you'd actually want to do is do this middle one, which is LTC initial assessment, which incorporates all of that. So that's what I'm going to do. But if you just remember there's a button for lifestyle and test on here, it will make sense when I go into this one. So it might be that, right, I'm going to do the bloods, but let me start asking you some questions. So we're going to go initial assessment. And this is when you can start collating everything. It's like, in a way, you don't really need to know what they've got. Or, I mean, you kind of do, but this template will guide you through it. It will basically only show you what you need to code for that patient. Now, if you see, you've got chevrons, so it's telling me I need to do the lifestyle page, blood pressure pulse page, cardiovascular disease page, diabetes, asthma page, mental health, and tests. If I try to go to COPD and click on the link, it doesn't do anything. So it only tells me where I need to go. And essentially, it's designed in a way for the HCA. This is not for the GP. They've got another one, or the nurse. This is more for the HCA. So it's designed in that way. So if it looks limited, it's done for a reason, but it's still getting the information. So what I could do is if I click where it says lifestyle, I could then just ask these questions. Remember, you can go to this anyway, but I'm going to do this quick. Please don't worry, just want to quickly add some stuff, but, I could put their weight and their height in. Oh my word, I'm making them 7 meters tall. Do they smoke? Do they drink? Does not use drugs, physically active, lifestyle. Again, I've been quick, but you could ask these questions and you're collating that information. So you don't need to do it again. Click OK, and then it would take me back there, and then I can start going through everything else. So then I might go to the blood pressure pulse, so I can either click the tab or the link, and then here. Now you might think, well, hang on, what's this doing? And it's saying you're screening for AF or screening for hypertension. You don't have to say that to the patient. You can just be like, oh, can I take your blood pressure, please? 120/80, and then I'll put your pulse in 75, and that's done. It has got other things, its pulse is regular, and it even gives you what's a red flag, which is again useful. If you don't know, I might not be a clinician, but I quite can clearly see if it's below 50 or above 100, I should probably let the GP know. So it's giving you that guidance. So, but it might be like, yep, collated that, great. And I could tick those if I deem relevant, but again, it's up to you. I could just go to the next page. Now the next page is because they've got diabetes, it's primary prevention of cardiovascular disease. They will need to have a Q risk at some point. I'm an HCA, I probably don't do the Q risk, and it does say, can you just make sure blood pressure, smoking, weight, and BMI, along with family history of CVD are complete? So it's like, well, actually, I've already done that on the lifestyle thing, so I don't need to do it again. So I've already got that information. I don't have to duplicate anything. I just need to ask them if they got a family history of heart disease. If I click on there, oh, they've already told me that. Is that still the case? Well, I imagine it would be, but I could add it if it's there, not there. I don't need to do this one because it's grayed out because they don't have that. So it grays out what you don't need. Heart failure, I would code because they've got heart failure. So it might just be, any breathlessness, any swelling, how are you feeling, or, a bit of fatigue. That might be enough. So again, it's up to you, but you can try and get as much information as you can in that initial appointment, and you just keep going. Diabetes page, I've already done the blood pressure, I've already done the weight. I can see that but it might be that I need to do the foot check, and I've got a link to it's probably what they already do. Do the foot screening, code anything I need, red stars are QOF, and then you move on. Asthma page. They might have filled out a questionnaire for asthma. I can check it because if I click on any of these, it's going to tell me if it's been done. I can fill in any gaps, collate that information as much as I can. So you can see if it's been done, and if it's not, I could ask it. These tabs aren't relevant. mental health, and then literally can you SMI's grayed out, but it would have questions for SMI. Dementia, they don't have dementia, but if they did, that would be lit up. But it does just say, how you feeling? Yeah, I'm fine. You know, if it was a depressed mood, I could potentially do the depression screening if I want to, but I could just go normal for now. And then I think that's everything. And then if I go to the test tab, this is where I do my bloods. And you could do the bloods first. Do you know what I mean? It doesn't matter. There's no right or wrong. It's just one template to do all this. And I could literally just be like, yeah, I got consent to do this. Blood sample's been taken. Consent to do, sorry. Yeah, blood sample taken. It was a random sample. There were no complications, and I've also done a urine. Obviously, I'm being flippant here. You would know exactly what you need to code, but it allows you to do it there. And then that button there, for those who use ICE or TQuest, whatever you use, that would launch that. So you can go on and do that from there. So you can do the blood forms, and you can see what needs doing. So as you can see, this template allows me to just go, right, information, do the bloods, job done. And if I click OK on this template, what it would do is it would go back to where I was. And I don't know if you saw that, but the well-being just disappeared. Can you see all the well-being stuff's been answered? So I didn't code everything so I can see what's outstanding. All the well-being's done, it's cleared. So that list has got shorter, and it does that in real time. So it's just worth knowing, for an easy patient, you could clear everything. And then once I'm happy, this is really important. I need to tick initial assessment done. If I tick that, it removes the patient from the invite reports. If I don't tick that, we'll just keep sending them an invite. So that is important. But the idea here is I've done the bloods, cleared all that information. Right, happy days. We'll be in contact when the bloods come back, or however you work, but that's essentially what's happening here. So I'd save the record, patient goes home, and then what happens then is, so I appreciate it's 10 minutes. So if I go back to reporting and clinical reporting, if we go back to our LTC folder, in here, we've got the review section. See, it says for a review all. Now, that report at the top says all is essentially saying all of these patients, and it tells you here, look, LTC annual review required as initial assessment between 3 days and up to 3 months ago, but the review's not being completed. That report is basically everyone that was seen by the HCA, ticked a couple of days later, 3 days basically for the bloods to come back, and I could run that one and I could go through the whole list. Or you might think, well, why is there so many? Just breaks it down. That's all of my cardiovascular, renal, and metabolic diseases. Or I just want to deal with patients that came in and got diabetes. I'll run that one. Or I just want to look at, mental health, or or respiratory asthma patients or COPD patients. So it will show you, it will break it down by condition, or it will just show you all, and it's those that have had the initial assessment. And you'll see on the left-hand side, we give you even more options. And again, there's no right or wrong. You've got this one, which only has one. So these patients have only got diabetes. So that's an easy clear. Just get rid of them. Not get rid of them, but you can check it. I know they don't have anything else that I need to be reviewing. Or they only have heart failure, or only have epilepsy, or only have asthma. So it does it like that. Or you've even got it in a group, only has LTCs in one group. So it would be those patients that only have conditions that fall into the cardiovascular, renal, metabolic group, fall into the mental health group. So patients will be on all three. We're just giving you the option to approach it how you want to approach it. So, but essentially that would allow you to do a notes review of all the patients that were seen by the HCA. And then what they can do is they can dive into the notes, and then they can decide this workflow bit you would have to decide, and we can help you with it when we do training for you. But let's just say I was doing a notes review. If I go back to our goalkeeper, our LTC template, and then I'm going to go now to the review tab. Now the review tab shows you the same thing as the initial assessment tab, except it doesn't say what bloods are needed because they've been done. If I scroll to the bottom, all of the bloods sit there. Look. I mean, again, ignore the actual bloods that have been done there, but that would have a table of all their blood results. And you'd be able to see under the heading where it says all reports in last month, you would be able to see the actual header or battery or whatever you call it from the labs. So you can see what came through and it in a table. So I can quite clearly see that's the results of our bloods. I can see what medication they're on. I can actually right click, issue, amend, stop. Do whatever you want to do. And if I scroll up, if you remember, I know all the well-being stuff's now been done because it's empty. So in theory, I can check the bloods and I can check if anything else needs doing. So if the easy patients, if the HCA's done everything, I'll be like, yeah, this is great. I don't need to see the patient. I'll just give them a text. And then you can complete the review. Or you might look at it and go, actually, this patient's got loads to do. I'll give them a call. Or you might think, let's book them in for an appointment. So that stage, you would do a notes review, and then you could decide how you want that to do, and you might create a thing which is like, I'll let this person put this in or that or whatever. So that's up to you. It just facilitates the ease of that. And then, because we need to fill in any gaps that were missed in the initial appointment for some patients, and for example, this one, it does need to happen because I can see it's empty. It's not empty. I've got the templates on the right. Now, that's the lifestyle template again. If there was anything missed, I can code it on there. But this time we've divided them up. So you've got all of your cardiovascular, renal, metabolic conditions in one template, all of your respiratory stuff in another template, mental health and other. Again, if the patient doesn't have a condition in that group, it will be grayed out. So if you only had an asthma patient, the only thing lit up would be respiratory. But again, it just allows you to work through like that. But if I go, so the idea is actually whether I'm with the patient or not with the patient, if I want to fill in the gaps, if I go to the CVRMs, this is designed more for the clinicians, but it's a similar vibe to the HCA's initial assessment. So you get this come up. This just shows you a view of stuff coded in the record already, but it's telling me what pages can let screening, primary prevention, heart failure, diabetes, CKD, because that's what they've got. All the other pages are relevant because they don't have those conditions. So if I go to the screening page, it's no different to what I showed the HCA, but it's just slightly more geared towards a clinician. Now, this is probably already been coded, like 120/80. Oh yeah, that was coded. So I'll just be like, yeah, that's fine. Normal. You know, their heart rate was this. Yeah, that's fine. It's normal. So I'm just finalizing things if it hasn't been done. If it has been, you don't have to, but it's just a way of doing that. All of this is grayed out because it's not relevant. Cardiovascular primary prevention. So again, I can fill in any gaps. You know, did they do this ischemic heart disease? Oh yeah, it's already been coded. So I can just do the Q risk. I can do the Q risk, and then I could go, yep, it's low. So you know, here's some education, blah 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 blah. So again, it just allows you to do finish the review off. But if all of this has been coded, I don't need to keep recoding. Heart failure tab, I can do a heart failure review. So again, you know, this has been done already, blood pressure has been done, it's fine, that was all done. So you know, oh, I can see that was coded, so yeah, they're fine. So here's you know, I reviewed them drugs, and here's a care plan, etc. So they can just do those final pieces and follow up. And then again, the diabetes, it's just, you know, you've got a link to your eight key care processes, but it's all been ticked off already. You can just fill in any gaps. Red stars are cough, fill out anything that needs to be done. Diabetes does go over 2 pages, so the second page has like the, you know, yeah, you're in target, here's some advice, just finishing it off basically. You know, prescribe you some more drugs, here's a care plan, here's an information leaflet, again, whatever you need to do. And then the last tab I think we need to do is the CKD. Now, to be honest, CKD EGFR's probably come in, so I'll be able to see what the result is and go, oh yeah, that's fine. So yeah, it's stable. I love it. I'm being very flippant, but I think you can see how this would work. You know, I just gave him some advice on this and that, job done. And you can basically just go through, and it only allows you to do the tab that's relevant for the patient. And by doing it that way, you're just basically finalizing, doing a notes review. But if you do it this way, you freed up appointments, because the HCA, if they've done everything, I could do this over the phone. I'll just finish it off, and therefore I freed up an appointment. You get the idea, hopefully. And then basically once they've done, the respiratory is very similar. If I click respiratory, just to show you, I think they've only got asthma. You can only get to the asthma page, and it's the normal asthma review. But again, if they've done that on the questionnaire, probably don't need to do anything. You can just finalize it. But again, it's up to you. And then once everything's been done, you've got an option of either saying annual review in amber or green. Now you might wonder why there's 2. Annual review will basically be like if you've got a patient with lots of things wrong with them, and I've done half of it and someone else is going to do the other half. That's like me going, done my bit, someone needs to finish it off. And what will happen, let me just go to the reports in the background, and I'll bring that back up so I can refer to it. So what we're doing, so clinical reporting. So at the moment, we were looking at the review all. If you tick that amber tick box, it removes the patient from that report, and it basically dumps them on this one at 4B, review to complete all. So, and then you can just finish it off. So it's just like a holding ground. You don't have to do that. If the patient's an easy patient and you've reviewed it all, then I could literally go to that, you know, look at it all. And if I'm happy, I would tick annual review completed, and it basically removes them from all of those reports. And essentially that is the final code, and that will basically get rid of them, for want of a better word. And then everything will reset on the 1st of April. So I'm running out of time now, but yeah, so I'm hoping that makes sense. But at its purest form, if you get rid of all what we have to do, our reports are basically going, this birth month, invite and code, invite code, and they'll stay on there until initial assessment's been ticked. It removes them, they fall onto the review bit, and then once I've done everything and I'm happy, I tick that, and then it gets rid of them off the reports. Everything else is obviously what you do, but at its purest form, it's just those codes. That is literally it. And it will remove them. So I'm hoping that makes sense. Just a couple of other things on the reviews there's reviews to chase. So you've got reports that will help you be like, they had their initial assessment more than 3 months ago, but no one's finished off the reviews and stuff like that. So again, that's useful to know. And again, that just allows you to make sure you can mop up those and do that sort of thing. And then just very lastly, we've got the evaluate section. So that just shows you activity last month or this fiscal year. So this would be like, how many annual reviews did we complete? How many initial assessments did we do, etc. And then the same, but from the 1st of April rather than last month. So they just help you manage that as well. I'm conscious of time. I've gone through a lot there. Dave, any questions on that bit?
No, I think pretty much everything has been answered on the chat, on the Q&A. So if there are any further questions, everyone, just feel free. We are almost out of time, but I guess myself and Nathan could hang around for sort of 5 minutes or so just to answer any further questions. I'm just going to share my screen, everyone, just to finish off and draw to a close. So if you bear with me a second. So obviously, as Nathan said there, that is quite a lot of information to take in on a Tuesday afternoon, a Tuesday lunchtime. That's not to say we can't support you in any other way. If after today you feel like you maybe need to take a step back, discuss it amongst yourselves, amongst everyone else in the practice, you can see that this approach is going to involve pretty much lots of teams within the practice. So there does need to be that discussion. But what we are doing to support everyone with that is holding these sessions bi-monthly. So again, come August time, there'll be another advertisement of another session. So you can join as many of these as you want to until you're comfortable. Obviously, we've touched on it a few times in the last hour or so. All Ardens training is free. We are here to support you. So if you do want to book any training, one-to-one with your practice, then training@ardens.org.uk. Just reach out and we get some training booked in. Support articles have been posted onto the Q&A as well. And as you get the recording, you'll have further support articles there as well. If you do maybe implement this sooner rather than later, and you do run into sort of questions and queries, then again, our support team, support@ardens.org.uk. Any queries or questions, just fire them through to support. And then finally, before we finish off, if you've got your phones at the ready, scan that QR code. It will allow you to fill in some online feedback for today's session. We are interested in feedback on how we can improve. I guess one of the things we've learned today, Nathan, is an hour isn't a huge amount of time to go through the amount of information that we do. So please feel free, everyone. I'll just leave that on the screen. So if there is any feedback, please send that through. If any of you do have those final questions you want to pop onto the Q&A, feel free. But if not, thank you all for your time this afternoon. Thanks for joining. Hope you all found it useful. And you know where we are if you need to reach out and get any further training. So thanks once again and take care. Myself and Nathan will stay on for a few moments just in case there are any further questions. But thanks everyone. Take care.